هناخد anatomy of the liver, bile tract, and pancreas. أول شيء we're going to start with a case scenario. عندنا فاطمة, she's 42 years old, obese, multipara, meaning she had 2 or more pregnancies, and she presents with progressive jaundice, lethargy, nausea, vomiting, and right hypochondriac and epigastric pain, radiating to the back below the right scapula. On examination, they found swelling in the right upper quadrant of the abdomen, corresponding to the tip of the right ninth costal cartilage. وهنا في يعني أسئلة. It's asking us which organ it might be related to. This is going to be the liver or gallbladder. وبعدين the tip of the ninth right costal cartilage is going to be a classical surface marking of the fundus of the gallbladder. وبعدين when we think of jaundice, زي ما أخذنا بالbiochemistry, we're going to think about hyperbilirubinemia, and this is going to be, in this case, posthepatic. This is a very classical scenario. We have a right upper quadrant pain combined with jaundice and radiation to the back. فعلى طول we want to be thinking of obstruction of the common bile duct, whether that be a stone or a mass. So back radiation to the scapula suggests irritation of the diaphragm. So there's referred pain from C3 to C5. But then other clues that they mentioned are the 4 Fs, female, fat, fertile, and 40. And so we want to think of gallstones. وبعدين at the ninth costal cartilage tip, زي ما قلنا, it's a very classic gallbladder fundus surface anatomy. But بالنسبة للliver, it's the largest gland in the body. As we know, it has digestive and extradigestive functions. بالنسبة للdigestive, is going to be bowel production and excretion, extradigestive, filtration of the blood, excretion of bilirubin, metabolism, زي ما احنا عارفين من الفارما, storage of multiple substances or synthesis of multiple substances. اللي يهمنا هنا إنه there is a dual blood supply to the liver. We have 30% through the hepatic artery, and this is going to be oxygenated blood from the heart. And then 70% is going to be through the portal vein, and it's going to be nutrient-rich blood from the intestine. But the liver is a wedge-shaped organ. It's going to be primarily located in the right hypochondrium and the epigastric region. وطبعا we need to know this for clinical scenarios. And it can also extend into the left hypochondrium. It has 2 surfaces, the diaphragmatic and visceral surfaces. هنا اللي يهمنا في diaphragmatic surface, we have 3 things. We have the subdiaphragmatic recess, or also known as the subphrenic recess, and this is going to be divided by the falciform ligament into a right and left recess. بعدين عندنا الhepatorenal recess, and this is going to be also known as Morson's pouch, as you can see in the image here. طبعا this is going to be important because this is going to be the most important area for accumulation of fluid or pus مثلا if the patient is supine. وطبعا عندنا the right extraperitoneal subdiaphragmatic space, or more simply the bare area of the liver. من اسمها, the space has no peritoneum, and it's clinically significant because it's a connection between the abdomen and the thorax. وهنا عندنا سؤال, what are the boundaries and significance of the right extraperitoneal subdiaphragmatic space اللي هو the bare area of the liver? Is going to be bounded by ligaments, as you can see in the image. وبعدين it's significant, as we mentioned before. It's an area where infection can spread directly to the thorax. وبعدين we can have cancer metastasis contract through the diaphragm. وبعدين lymphatics here are going to drain to the posterior mediastinal lymph nodes, unlike the liver, which is going to drain into the celiac nodes. هناخدها بعد شوي. بعدين بالنسبة the bare area, we also have portosystemic anastomosis pathways. So the veins draining the liver can communicate with diaphragmatic veins, and that's eventually going to drain into the azygous system. But بالنسبة للvisceral surface of the liver, it's going to be covered with visceral peritoneum من اسمه. لكن we need to know the exceptions. It's going to be covered with the visceral peritoneum except for at the fossa for the gallbladder, as well as the porta hepatis. And it contains the porta hepatis, and it's related to the esophagus, the stomach, the first part of the duodenum, the lesser omentum, the gallbladder, the right colic flexure, the transverse colon, the right kidney, and suprarenal gland. But the porta hepatis is going to be the gateway to the liver, and it has multiple structures that we have to have memorized: the right and left branches of the hepatic artery, as well as the portal vein, as well as the hepatic ducts. وبعدين عندنا sympathetic nervous system, sympathetic and parasympathetic nerve fibers. بعدين we also have hepatic lymph nodes and lymphatics. But so what is attached to the porta hepatis? This is going to be the lesser omentum, containing in its free margin the hepatic artery proper, the portal vein, and the bile duct. ولازم نكون حافظين their positionings, which forms the anterior boundary of the epiploic foramen, also known as Winslow's foramen. The anterior boundary here is going to be the hepatoduodenal ligament. The posterior boundary is going to be the inferior vena cava, اللي عليه سؤال, I think, in the next coming slides. But بالنسبة لي, the liver's ligaments, we have two types of ligaments, fibrous ligaments and peritoneal ligaments. Fibrous are going to be remnants of the fetal circulation, and then the round ligament and the ligamentum venosum. Peritoneal, they're going to connect the liver to multiple structures. So what connects it to the anterior abdominal wall, and then a falciform ligament, and what connects it to the stomach and the duodenum is the hepatogastric and the hepatoduodenal ligament من أساميها. وبعدين what connects it to the diaphragm is going to be the left and right triangular and anterior and posterior coronary ligaments, as you can see in the image here. وبعدين what we need to know here is that these ligaments aren't what fix the liver in place. What does is the intra-abdominal pressure, as well as the hepatic veins entering the inferior vena cava. You can label the ligaments here, لكن الدكتورة مرت عليها سريع. طيب بالنسبة لل MCQ, which one of the following structures is separated by the opening of the lesser sac from the free margin of the lesser omentum, or which one of the structures forms the posterior boundary of the epiploic foramina? زي ما قلنا فوق, it's going to be the inferior vena cava. طيب نجي على lobes of the liver. We can divide the liver anatomically or functionally. Anatomically, we're going to have the right and left divisions. The right division is going to have the quadrate and caudate lobes, and this is going to be based on surface features. لكن اللي يهمنا functionally, this is going to be based on blood supply and biliary drainage. This is going to be more important surgically or physiologically. So when it comes to the physiological divisions, it's going to be mainly focused on the left lobe. The quadrate and caudate lobes are actually going to be functionally on the left. But when we segment the liver, it's going to be into 8 segments. أول شيء, we have 3 planes dividing it. عندنا the principal or mid plane, and it's going to divide it in half. And we're going to have the middle hepatic vein من اسمه. وبعدين we have 2 vertical planes اللي هو the right portal fissure, also known as the right intersectional plane, and we're going to have the right hepatic vein as well as the umbilical fissure or the left intersectional plane, and this is going to have the left hepatic vein we also have the transverse hepatic plane, which is going to divide it horizontally. But functionally, the left lobe is going to be the quadrate and caudate lobe with segments 2 to 4. بعدين, the right lobe is going to be from 5 through 7. So زي ما قلنا بالبداية, the quadrate and caudate are functionally left, even though anatomically we said that they're right. هنا is somewhat repetitive. The segmentation is going to be in a clockwise fashion. وبعدين, these features are extremely consistent between individuals, وهذا يهمنا surgically and clinically. طبعا, when we want to resect a segment of the liver when we have metastatic disease. فهذا يهمنا because each segment has its own blood supply and drainage system. وبعدين, from a surgical perspective, a right hepatectomy would involve dividing the liver in the principal plane, and we're going to remove segments 5 through 8, and this would leave segments 1 through 4. فهنا we have a true or false. And then the functional right lobe includes segments 5 through 8. This is true. The quadrate lobe is functionally part of the left lobe. This is correct. The caudate lobe is functionally a separate segment, also correct. And the anatomical left lobe includes segments 2 and 3, correct. And blood supply, arterial is going to be from the hepatic artery, 30%, زي ما قلنا بالبداية. Venous supply is going to be from the hepatic veins and the portal veins. لكن يهمنا هنا أكثر portal veins. It's going to be 70%. The hepatic veins don't actually accompany the portal triad structures, and they run independently, which is why they're also referred to as intersegmental veins. طيب نرجع للportal vein. It's going to be formed by the splenic vein and the superior mesenteric vein. The splenic vein is going to drain the spleen and stomach, as well as the left lobe. The superior mesenteric is going to be from the intestines and the right lobe. By then, something that the doctor mentioned was that their junction forms an angle, and that's what causes blood from different organs to flow preferentially into different lobes of the liver. بالنسبة lymphatic drainage, lymph nodes in the porta hepatis are going to drain into the celiac nodes. وزي ما قلنا أول, the vessels that pass from the bare area through the diaphragm are going to drain into the posterior mediastinal lymph nodes. بالنسبة nerve supply, it's going to be from the celiac plexus, which is going to surround the celiac arteries. By then, the anterior vagal trunk is going to give a large hepatic branch, which also carries branches to the pylorus. But here we also have a clinical scenario. And then Ahmed with chronic active hepatitis. He's jaundiced, confused, he has ascites, hepatosplenomegaly, pulmonary erythema, spider nevi, caput medusa, and ankle edema. الزبدة هنا, this is a classic picture of portal hypertension. What happened here is that there's portal systemic shunting, which results in esophageal and rectal varices. فهنا liver cirrhosis can cause portal hypertension. So the potential causes of hematemesis, اللي هو vomiting blood, is going to be esophageal varices. And so the rupture here is what causes massive upper GI bleeding. But then to answer the second and third question, we can look at this image. بالنسبة لي, the vessels that anastomose at the sites, we have three main important sites, اللي هي lower esophagus, the umbilicus, and the anal canal. At the lower esophagus, we have the left gastric and the azygous vein. طبعا left gastric is going to be portal and azygous is going to be systemic. And the clinical manifestation is going to be esophageal varices. بعدين بالنسبة للumbilicus is going to be anastomosis of the paraumbilical and superficial epigastric veins. Obviously, it's going to manifest clinically as caput medusa. بعدين بالنسبة للanal canal عندنا the superior and middle and inferior rectal veins. And this is going to manifest as hemorrhoids. But بالنسبة للsurface anatomy of the liver, this is important. It's going to be from the ribs 7 through 11 in the mid-axillary line. هذه يعني تسهيل للحفظ. The liver biopsy can be taken normally in the mid-axillary line in the 8th or 9th intercostal space. And so when we take the biopsy, it should be during expiration to reduce the risk of lung injury. But in our case, can we take liver biopsy from the regular space into an 8th or 9th intercostal? And the answer is going to be no, because Ahmed has ascites, coagulopathy, distortion of the surface anatomy, and potential varices, and that causes it to be unsafe. And so an alternate approach we can take here is transjugular liver biopsy, and this is where we insert the needle through the internal jugular vein, and then we can go through the hepatic vein to the liver. And so this is better because the bleeding will drain into the venous system instead of into the peritoneum. And this is going to be safe in ascites, coagulopathy, obesity, as well as portal hypertension. But نجي للbile tract, and it's going to be the duct system of the liver. Is going to consist of the right and left hepatic ducts. And then the right hepatic duct is going to drain the right lobe, and the left hepatic duct is going to be draining the left lobe, as well as the caudate and quadrate lobe, which is why the quadrate and caudate are functionally left. بعدين عندنا, they join together at the common hepatic duct, and they're going to be formed in the porta hepatis by the union, as we mentioned, of both hepatic ducts. نجي للgallbladder, it's going to be a pear-shaped sac. It's going to be on the visceral surface of the right lobe of the liver in a fossa between the right and quadrate lobes. In terms of its parts, عندنا the neck, the body, and the fundus. And the fundus is important because it lies near the transverse colon. بعدين بالنسبة للduct, we have the cystic duct. As you can see, it coils. And so this is the spiral duct. The duct has a spiral lumen, which allows bile to pass both in and out. فزي ما قلنا, we have the left and right hepatic ducts, بعدين we have the common hepatic duct, وبعدين we have the gallbladder itself and the cystic duct, ودحين نجي للcommon bile duct. But بالنسبة لي, the gallbladder itself, its blood supply is going to be from the cystic artery, and this is going to be from the right hepatic artery. بالنسبة للnerve supply, sympathetic is going to be from T7 to T9 through the celiac plexus. Parasympathetic is going to be from the right vagus. بالنسبة lymphatic drainage is going to go through the hepatic nodes and then through the celiac nodes. But then its functions are going to be to store and concentrate the bile after the liver makes it. نرجع للcommon bile duct. It's going to be here. بعد ما the bile leaves the gallbladder, it's going to reach the common bile duct. بعدين عندنا structure here يهمنا اللي هو the ampulla of Vader. And this is essentially going to be the junction or the meeting point of the pancreatic and common bile duct. وبعدين, this ampulla is going to open into the lumen of the second part of the duodenum at the top of the major duodenal papilla. زي ما انتم شايفين هنا, the duodenum. وبعدين, the terminal parts of both ducts as well as the ampulla are surrounded by circular muscle. This is known as the sphincter of Oddi. So عندنا, where both of these ducts end, as well as at their junction, زي ما انتم شايفين هنا, we have these circular rings of muscle known as the sphincter of Oddi. But بالنسبة للأسئلة هنا, how does the anatomy of the bile tract help explain the patient's symptoms? When we have obstruction, so in our case, مثلا a stone, we're going to have accumulation of bile, and so it's going to go through the bloodstream, and we're going to have jaundice. That's what causes the conjugated hyperbilirubinemia, as well as the jaundice, زي ما قلنا. And so the bile retention is going to irritate the hepatocytes, اللي هي the cells of the liver, and it's going to cause pain, while lack of bile in the intestine leads to pale stools, as well as fat malabsorption. وبعدين, why is the pain referred to the back? The back pressure, لا معلش, the back pressure is going to enlarge the gallbladder and produce the palpable swelling that we described بالبداية. But then we also have to remember the 4 F's when it comes to cases, اللي هي female, fat, fertile, and 40. But نجي للpancreas. As we know, it's a mixed gland, meaning it has two functions, exocrine and endocrine. Exocrine is going to be when it secretes the pancreatic juice, and this contains inactivated digestive enzymes. But then endocrine is going to be producing hormones through the islets of Langerhans. But بالنسبة للlocation, it's going to be epigastric and left hypochondriac, meaning إذا درسنا the 9 regions, and then it's going to be epigastric and at the left hypochondriac, معلش يعني هنا. طيب, it's going to be retroperitoneal, meaning that there's no mesentery. وبعدين it's divided into the head, neck, body, and tail. هنا the head is going to show an unkinete process. I'm not sure if I'm pronouncing it correctly. وبالنسبة لي, the neck, it's going to be significant because the formation of the superior mesenteric vein as well as the portal vein are going to happen behind it. وبعدين the body is going to run upward to the left, زي ما انتم شايفين, behind the stomach. وبعدين the tail is going to reach the hilum of the spleen. This is clinically significant. It's the only intraperitoneal part. وبعدين it can also be affected when we have مثلا surgeries in the spleen. But بالنسبة للpancreas, anteriorly, it's going to be related to the stomach bed. فمثلا, if we have a question about stomach ulcers in the posterior stomach, it's going to affect the pancreas. So from right to left, it's going to be related to the transverse colon, the attachment of the transverse mesocolon, the lesser sac, and the stomach. But then posteriorly toward the head, from right to left, where we have the bile duct. Toward the neck, we have the portal and splenic veins, the inferior vena cava, the aorta, the origin of the superior mesenteric artery, the left psoas muscle, the left suprarenal gland, the left kidney. وبعدين at the tail, and this is important, is the hilum of the spleen. But بالنسبة لي, the duct system, similarly to the gallbladder, its main duct is going to join it at the ampulla of Vader. تقريبا هنا كذا. It's going to open into the second part of the duodenum. We also have the accessory pancreatic duct, and that's going to open separately in the second part of the duodenum, about 1 inch above it. زي ما انتم شايفين بالصورة هنا, this is going to be the main duct, this is going to be the accessory duct. But بالنسبة to arterial supply, we have the head is going to be supplied by the superior and inferior pancreatic duodenal arteries. The superior is going to come from the celiac artery, inferior from the superior mesenteric. بالنسبة للbody and the tail, it's going to be branches of the splenic artery, also coming from the celiac artery. So as we can see, its main supply is going to be from the celiac, but also from the superior mesenteric. بالنسبة للvenous drainage, the superior pancreaticoduodenal and inferior as well are going to join the superior mesenteric vein, and the veins from the body and tail are going to join the splenic veins. The lymphatic drainage, and then it's going to drain into the celiac and superior mesenteric lymph nodes. بالنسبة للnerve supply, parasympathetic is going to be vagus, sympathetic is going to be segments 5 through 12 of the spinal cord. لكن هذه ما أعتقد إن الدكتورة mentioned them. المهم نجي للclinical applications. هنا we have acute pancreatitis. هنا the pain is going to radiate to the back, as we mentioned, and it's a medical emergency. If we have trauma to the pancreas, it can crush the pancreas. وبعدين if we have مثلا a surgery on the pancreatic tail or a splenectomy, a splenectomy can affect the pancreatic tail. فمثلا the patient can develop diabetes. بعدين زي ما شفنا بالمحاضرة, if we have a splenectomy, we have to be careful at the tail of the pancreas because it's found at the hilum of the spleen. If it's injured, we can have leakage of digestive enzymes, and this can cause bleeding and complications. طبعا جزئية الself study مرة بسيطة للspleen. As we know, if we can palpate the spleen, that means we have a pathology. It's a lymphatic organ. It's located in the left hypochondrium. So if we draw the 9 sections, it's going to be here. The long axis is opposite to the 10th rib. This is important for clinical scenarios. بالنسبة للrelations, we have two poles, two borders, a notched upper anterior border, وبعدين the lower border is blunt. We have two surfaces, the visceral and diaphragmatic surface. The visceral surface is going to have the hilum that has the vessels, as well as the tail of the pancreas, as we mentioned, and the surface is related to the stomach, left colic flexure, and the left kidney. The diaphragmatic surface is going to be related to the 9th and 10th ribs. When it's enlarged, we're going to take this again, but when it's enlarged, it's going to go to the right side downwards near the umbilicus, right in the right iliac fossa, and it's going to go obliquely. It doesn't go left or down specifically because it's stopped by the phrenocholic ligament, as we can see here. But بالنسبة the spleen, it's completely covered with peritoneum, and it has two important ligaments. The lenorenal ligament, also known as the splenicorenal ligament, is going to connect the hilum of the spleen to the left kidney, and this is important. It transmits the tail of the pancreas and the splenic vessels. So if we have a splenectomy, زي ما قلنا, it has a potential to injure the tail of the pancreas. بعدين عندنا the gastrosplenic ligament. It's going to connect the hilum of the spleen to the greater curvature of the stomach, and it transmits the short gastric and left gastroepiploic vessels. بالنسبة the neurovascular supply, splenic artery, splenic vein بكل بساطة. The lymph nodes along the splenic artery are going to eventually drain into the celiac lymph nodes. بعدين the nerve supply is going to be from the celiac plexus. زي ما قلنا, in splenomegaly, it doesn't descend directly downwards because of the phrenocholic ligament. And so instead, its anterior border is going to go downwards and to the right in the direction of the right iliac fossa. As we mentioned, we can't normally palpate it, but once it grows to 3 times its normal size, we can. And then a hypersplenism is it causes anemia due to massive destruction of the red blood cells when the spleen is overactive مثلا. طيب آخر شيء نيجي للSAQs. Mention the arterial supply to the pancreas. As we mentioned, عندنا the superior pancreatical duodenal arteries as well as the inferior. And then for the body and the tail, we have the branches of the splenic artery. Most of it is going to be from the celiac artery. But then follow the journey of bile secretion from the quadrate lobe of the liver to its fatty food target in the GIT. As we mentioned, quadrate is going to be functionally left. So it's going to go through the left hepatic duct, then the common hepatic duct, that is going to go through the gallbladder, and then the common bile duct, and then it's going to go through the ampulla of Vater, and finally it's going to enter the duodenum at the major duodenal papilla. بعدين the peritoneal ligaments connecting the liver to the diaphragm, عندنا the coronary ligaments as well as the triangular ligaments. بعدين بالنسبة لي the peritoneal recesses that are related to the diaphragm, اللي أخذناها بالبداية, all 3 of them. The subdiaphragmatic recess, the hepatorenal recess, this is the Morrison's pouch. وبعدين we have the right extraperitoneal subdiaphragmatic space, also known as the bare area of the liver. آخر شيء هنا we have a MCQ. Which part of the gallbladder comes in contact with the colon, and that is going to be the fundus.